Cardiovascular care is currently one of the most highly sought-after specialized healthcare services in the world, according to the World Health Organization, who describes cardiovascular diseases as the major cause of death globally, resulting in an estimated 17.9 million deaths, or 31% of the annual global mortality. To help address this, a leading hospital group in Nigeria, the Limi Hospital Group, set up and launched an ultra-modern cardiovascular multi-specialty hospital complex in Area 11, Garki, Abuja, called CardioCare Multi-Specialty Hospital. The Minister of Health, Osage Enanire, at the official launch of CardioCare Multi-Specialty Hospital, described the facility as a laudable project, noting that the specialty hospital meets and exceeds healthcare standards required for this level of highly specialized cardiovascular medicine. The minister encouraged more private sector investment, both independently and in partnership with the federal government.
With our population, we don't have enough of the specialties, and also we don't have enough of even the human resources available. So it's encouraging to see that the center like this exists.
And the essence is that they want people to get excellent medical care that is affordable and is easily available.
Health experts at the event say that the facility would augment the ability of Nigerians to receive treatment for complex cardiovascular problems without having to travel abroad, a step in the right direction to stop medical tourism and an added advantage to the health system, which will support universal health coverage.
So if there's a center here, it's not an issue of I want to. It's the issue that the center is here. It's definitely going to be cheaper and it's going to be much easier and safer.
Nigerians who have previously sought specialized care abroad were compelled to start looking this kind of country, looking for medical attention this kind of country.
So some of these things we had to travel abroad to really not see how it is done. Now it is right here in front of us, right in front of the FCT, and we feel that 90 minutes for anyone in Nigeria. I'm so sorry they denied the visa. Next time, the machines are right here. You don't have to go again.
The Limi Hospital Group is one of the leading healthcare providers in the Federal Capital Territory. Founded in 1982, the range of medical services offered include adult and pediatric clinical cardiology, interventional cardiology, endocrinology and diabetology, cardiac and vascular surgery, neurology and neurosurgery, nephrology and dialysis, hepatology and gastroenterology, critical and intensive care, pulmonology, rheumatology, general internal medicine, and emergency medicine. The range of surgical services are open heart surgeries, kidney and organ transplants, vascular grafts, access and repair, neurosurgeries, reconstructive surgeries, and so on. Medical Director of CardioCare, Dr. Onidamola Awofishoye, at the event said the hospital has successfully carried out over 70 minimally invasive interventional procedures between February and November 2020. He also noted that chances of survival after a heart attack can be improved if the patient is rushed to a cath lab within 60 to 90 minutes.
We've done over 70 successful procedures, heart procedures, complex heart procedures, opening up arteries, putting devices in the heart to make it work better, and helping with heart beat better.
The hospital is strategically located to ensure easy access within the country. The Executive Governor of Ondo State, Oluwarotimi Oduayo Akeredolu San, who was unable to be at the event, sent a goodwill gesture and expressed optimism about how the hospital will be a center of excellence in cardiovascular care services in Nigeria while improving the healthcare sector in the country.
You have been wonderful, young men, and no doubt the country is blessed to have you. And I know your center, which is a multi-specialist hospital, will sure be a medical center of excellence in the country. I wish you well. And I thank God for seeing you to this time. I want to urge you to continue your good works. have benefited from your multidisciplinary treatment, and this hospital will sure be great.
The Limi Hospital has evolved into the private healthcare hospital chain it is today as a result of a focus on quality care, precision care, patient-centered multi-specialty care, and a commitment to consistent improvement.
We did the basic yesterday. If you don't do the basic, if you're not here yesterday, you're almost wasting your time somehow, but I'll do a small recap of the basic. We went through how to do all the things properly. If you don't do that one, you cannot jump here. You cannot jump here. Okay, so if you don't do that one, you cannot jump here. If you look in your jotter on pages 33, no, from 31, from 29. Where did it start from? Yeah, from pages 29, you will see different algorithms for life support. Okay, if you contact me later, maybe we can do a big one for you. We have big ones around our hospital that we paste. If you copy it and you paste it in your hospital, please give us some small credit. Just put small credit there. So that you know say we try small. Okay, so from 23, you will see algorithms. These algorithms you must go through them with your staff over and over and over again. Because when it starts, you need to, now I'm going to also give you a website where you're going to use to practice. It's not our website, but I'm going to give you where you're going to use to practice the ACLS readings. So once it gets to ACLS, it's more about knowledge. It's not about what you are doing and what you are not doing. Okay, so we'll go straight into it. Have we seen it on our books? The different algorithms. We're going to use some of them. It's not complete, but there are quite a number here. Okay, are we all together? Hello? I think we have found it. I've given you free textbook. Okay, my name is Sid. Page, I think from, yeah, okay. 30. This one cut off, the name cut off of this one. Check responsiveness, defibrillation. Okay, this normal BLS. Cardiac arrest. 31, 32, 33. Okay. So we'll go straight into it. What is ACLS? Advanced Cardiac Life Support. You can sit down, sir. Advanced Cardiac Life Support refers to a standardized algorithmic. Algorithmic means that step by step, every step is a new question, every step is a new question. Step-by-step set of treatments that are used to treat life-threatening cardiovascular conditions. Every doctor, every nurse must know this. And for those of you that have tried to Japan, you know that they will tell you, if you don't have this, don't come here. Every doctor, every nurse must do this. Now, typically an ACLS class is about 8 people. It's more in-depth. I don't think there's anybody that charges less than 120,000 for an ACLS class. Okay? So there's only so much we can do with this whole audience, but we will try our best. You will at least have enough knowledge to do what you need to do part-time for now, just like we did for BLS. Okay? So that is ACLS, a set of clinical guidelines. It is for urgent and emergent treatment. So some of them are urgent, some of them are emergent. That is, some of them you must do something immediately. There is no time to call me, there's no time to refer, there's no time to be shouting. You are the person, you are the last hope of that individual, and they are in your hands. And if you don't handle that person well, in my mind, you are going to answer to God. That is how I see it. Okay? So it's a set of guidelines, urgent and emergent, for life-threatening cardiovascular conditions that will cause cardiac arrest. So some of them have not yet caused a cardiac arrest. But as you see them, it's just a matter of, remember when we were doing ECG, I said this one will turn to cardiac arrest. If you don't do anything and say, no, nothing is happening, the person is still breathing, you are just, sometimes they are even talking with you. There's one man that came to the hospital. He was talking. Politician, he refused. You remember that guy? He was supposed to get to appointment. He didn't get it finally. He refused our admission. We had to start doing things. Even he had to sign a DAMA form. Because they will either cause or they have already caused. So either a person is having a cardiac arrest or what he's having now is going to lead to a cardiac arrest if you don't do anything. So what you do, the procedures, the medications, and the techniques, that is what constitutes ACLS. Is that simple? ACLS, the sets of procedures, the decision tree, the set of clinical guidelines that we use. All these guidelines have been tested over time. We're not here. We tested over time. There, people keep on reporting. You know, for example, if we have reported all the things we have done in cardio care, the one we survived, the one that we survived, then other people will report their own. After a while, we can find what is working for Nigeria and what is not working for Nigeria. So they have national registries and national institutes. Their institutes of health, their ministry of health are collecting those data and, you know, working on it. Here, you know, it's something else. Okay, so that's how we go. So what we are using is what they have a lot of time in most of the cases. In some of the cases, I will tell you what will work in Nigeria. So some of the things are there. We don't have those things. I will tell you what we use in Nigeria and what you can do in the meantime. So ACLS steps in my mind. Number one is the BLS and CPR. Then the remaining parts of the ACLS are these other three parts. Crisis resource management, identification of the rhythm and the treatment, and you do that with electrotherapy. That is either you are cardioverting, you are defibrillating. Both cardioversion and defibrillation involve shocking. The difference between cardioversion and defibrillation is what? Is the voltage. How many people have something like this in your facility where you can adjust the voltage? How many people have something like this? Show of hands. 1, 2, 3. Don't worry, by faith, let's learn it. You must have this. You must have this. You should not be going near the theaters, operating on very sick patients, hypertensive, diabetics. You don't have this. You have anybody with heart attacks, hypertension, on admission, diabetics, and you don't have this, you are looking for trouble. And you know how it is. It is just one person, maybe 1,000, that will embarrass your entire hospital. This is a little bit expensive. And unfortunately, this is one of the things in a hospital for those in private sector that you cannot really get your money back for. A defibrillator standard costs something around 5 million or thereabout, 4 to 5 million. A full one. And this one I'm holding here, maybe costs close to 7 million, also has an AED. So you could turn it to AED. If you don't know what you are doing, just turn it to AED and put it to still work. And when you want to do ACLS, you can also now adjust it. In addition, you can use it to pace the person. So if the heart rate is too low and you have given what you cannot do, you take these pads, put one in front, put one in back, and turn it to a pacer and put on, and it will start pacing the heart. So that you can transport that patient safely to get to cardio care. We can now implant a pacemaker or put a temporary pacemaker into the heart. Without that, there's no way you can keep that rhythm up till you get to a place that can do that. Do you understand? So you should have this or something like this. It typically has batteries. You should be charging it every day. It should be somebody's job to go around, check all of these things, and charge it. On the slides also, I will give you a list of things that should be in your emergency trolley. Okay? And so you should also have them in your clinic. So you go back and prepare. Many years ago when I was in the government hospital, I complained. I wrote, we fought. I said it's not. The next time I heard it, one of our professors had an issue. This is how we went to park to go and be waiting for drug to come from Lagos. So you don't ever know, God forbid, who will need it. So always prepare your center, that they should not tell you that somebody that you know is in your center and you say, leave that place. Prepare your center so that, God forbid, if something happens to you in your clinic, you can be resuscitated properly. Train everybody. Go back. The one you have learned, use it and train. And these videos are on YouTube. It's Broadcasting Live. You go to Cardio Care on YouTube, you see yesterday's own and you see today's own. Okay, and you see our previous videos on different things, in depth. So, crisis resource management, identify the rhythm, and then treat the rhythm, manage the airway, and then specialized life support things, different higher-end gadgets that you can use. This essentially constitutes advanced cardiac life support. Okay? You will not find this like this if you read it online. It's always somehow. This is, I've been working throughout last night to find a way to break it down. Still, I don't think it's simple enough. But I think this is okay. Okay, so recap. Remember I said BLS is the start? Recap. If you don't do a good BLS, you will not get to ACLS. Patient will have died. So in the BLS, the first thing you do after you have confirmed that the patient is unresponsive, doesn't have a pulse or a heart rate, and is not breathing right, unresponsive, cardiac and respiratory arrest, is you call for help. Help is bringing extra hands, defibrillators. If you have a good system, you should be able to press a code for everybody to come in. You should have a code blue team, which typically consists of the most experienced people in the facility that you should be able to call that should start coming. And the people that know how to at least get airway, you should have that team on standby. And the bigger the hospital you are, the more likely you should be able to have such people. Okay? So you should call a team, you should get a crash cart. How many people have a crash cart in their facility? 1. So you are going to go and do it. It's not a bad thing. They should carry catapult like this. Put wheel under it and put cupboard. Shikena, you have crash carts. Hello? Or you can meet maybe Codex, I don't know if Codex has, or any of the instrument suppliers. It's about 400,000 or so. That one is the proper one. It has the backboard that you can put under a patient when you are doing CPR. It has all the cabinets where you can put your drugs nicely. It has the place where you can put your drugs, your AED, and where you can hang your pole. So you should take some time and invest in it. Okay, I don't know if any of our partners has. I'm not sure. Vaslovas. No, Vaslovas is mainly drugs. Okay, so you should have a crash cart. So some of us, this is something we are just putting together. You must have it. So when they say something is wrong with a patient, you drag that cart to the side of the patient. It's not that time you say adrenaline, then they go to the pharmacy. Adrenaline. Okay, then they come back. Atropine, then they start going. You know? A running doctor is not a very good doctor. Okay, fine. So the next thing is compression, and you have a firm surface. I'm just recapping. We did this in detail yesterday, remember? This is just the main points. 100 to 120 cycles per minute, 5 centimeters depth, minimize interruptions. Lock your palms and lock your elbows. Push from your shoulder. Push from your shoulder. Then airway and ventilation, 30 to 2. 30 compressions to 2 ventilations. If you happen to be somewhere that you don't have the ventilation or to good the bag, continue. Continue compression. Compression only is sometimes as effective as compressions with ventilation. So if you cannot do ventilation, just continue that compression. Don't let people be shouting all kind of things. Just be doing your compression. It has the potential to save. Firm mask, ambu bag. Remember the CE technique. We practiced it yesterday and we showed all of you. Then avoid pressing too much of our ventilation. Connect oxygen. Then bring your defibrillator. Connect your defibrillator. Put the pads. One under where? Where's the first pad? Under the right clavicle, and the other under the left breast, just under the nipple on the left side. Okay? You put that there. If you want to pace, it becomes front and back. If it's a child, it's front and back. Okay? You make sure that it does not touch each other. If you are using for a child, a lot of times you may have a voltage reducer for the defibrillator. So you have a voltage reducer. This is not one for the children's hospital. The children's hospital have their own. It has a voltage reducer. So it connects to a voltage reducer that reduces the voltage that goes to the child. Okay? But if you don't have that, still use the normal adult one. Okay? Last, you go shock and well, but let the child come back. I'm joking. But seriously, use the normal adult one. Okay? So put off open oxygen, no wet surfaces, just follow the prompts. It will analyze the ECG for you. So that is a BLS recap summarily. Okay, next is the crisis resource management. This is critical. A lot of times we don't normally pay attention to this. We're just looking for stuff. This is part of ACLS. This is where everybody must work together. So the key principles in crisis resource management are leadership, communication, and preparation. There's a fourth one actually, debriefing. But leadership, communication, and preparation. Leadership, communication, and preparation. What does this mean? There must be someone that is the team leader. So typically when I get to the side, they say, call a code, everybody. Brrr. Once I get there, I take the head of the bed. I am not the one pressing. I am not the one doing. What I am doing, I am coordinating the team. There must be somebody in charge. Whenever there is a crisis, it's not democracy time. It's military time. Okay? So that team leader is the person that does the global management, ensures that all tasks are carried out properly. So at that point in time, I will see somebody doing CPR like this. Krombe. Move. Go and be drawing drug. Okay? That time you see the wrong person, go and be recording. You need to assign people that will be recording your CPR also. So, you make sure everything is being done properly. You will coordinate communication. Anybody that wants to give an instruction will give it to you, and you will give them so that you can harmonize it. Not that somebody is saying give atropine here, somebody is saying give adrenaline here. You are the final person. You still will not be proud. You must collect everybody's expertise. Somebody says, sir, we have not done this. You take it, analyze it, and see whether it's something. So the most senior person in your hospital now, you are the most senior person, Abi. So far you came to ACS now you senior pass. Why all of you looking like me like that? Yeah, the most senior now. Now you know who goes supposed to do what. Okay, fine. So he coordinates communication among the team members, implement the management strategies, reassess performance, collates the experience and wisdom of the entire team. Yes, you will see at the organ, but you will still get input. In cardio care, everybody, cleaners, everybody will be taking turns. They are pressing the bag, sir. It's like what this oxygen is not doing. Somebody is doing that, sir. This something, that guy is not doing this proper thing. Well, they will move. They are invaluable. Everybody in your team. Let everybody learn it. It will not cost you anything. If they go and that person can teach them again. Okay? So let everybody in your team learn it because they are all important. At a time when CPR is getting to 30 minutes, sometimes we cannot press again. It's not that time you will not start teaching. I know the housekeeper and security men, they normally have muscles. Not them. They will press well. Okay? So they are a critical part. I'm not sure I can do CPR without them. Okay? See one that is coming in, came from the cath lab. No, we don't do cases without him. Yes, that's how important the person is. The person knows what drug to bring next, knows what ambu bag to bring next. It's critical. You cannot be running at that time. It's too late. Okay, so the next one is communication. Communication. All pertinent information goes through the team leader. Tasks are assigned by the team leader. The team member must repeat back the instruction. This is called a closed loop instruction. If I say give atropine 0.6 milligrams, you will repeat back to me atropine 0.6 milligrams before you will give. Do you understand? It's to make sure there are no errors. If I say give adrenaline 1 ampoule, you will say adrenaline 1 ampoule, then we will give. All of us will hear it. We will have assigned somebody that will be recording. For private practice, also for billing and for inventory purposes. But otherwise, you want to make sure that you document it properly. If you end up in court, you should be able to bring out everything. Okay? You should be able to bring out that you follow the proper steps. And you tell yourself, because tomorrow you should look at it and know where you can improve. So this is all part of ACLS. Okay? Then, extraneous personnel should be asked to leave. Some staff will just be there looking. Get them out. What are you doing here now? Okay? So team leader, get them out. Relatives not helping. Hey. They were just pressing the chest. Get them out. One person, they did tracheostomy, and the patient still died after everything. The woman said, if I cut your neck, will you survive? So get them out. Okay? Fine. Then debrief the team for learning points. After you have done, patient came back, patient did not survive. All of you should talk about, you sit down and talk about what you did right and what you did wrong. It helps you to improve for the next one. It helps you to improve for the next one. You say, we look for adrenaline today. Then you go back, you adjust it. So that eventually, it will become like an orchestra. Somebody is having a cold, people will just be moving around, pam, 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 everything is just coming out. The patient comes back to life. It's just fantastic. But if you don't do the debriefing, you will not learn from your mistakes like Nigeria. All right, and then finally, crisis resource management is preparation. Get vascular access immediately and early, IV or IO. I don't think many people do IO. You need an intraosseous set, a drill to the bone so that you can set a line when you cannot get any line. So IV or IO, oxygen should be ready. So you should not run a hospital if you don't have oxygen. Okay? Yes, I read in the papers they say there's no oxygen in one place. Somebody came with COVID, they're looking for oxygen around Abuja. You should not run a hospital without oxygen. Then you should have a way to monitor oxygen saturation. ETCO2 is very good. If your monitor can get ETCO2, fantastic. It has some extra cost, but it's very important. ETCO2 is the most reliable means to tell you, A, whether your CPR, you are doing a good job, and B, when to stop CPR. Okay, so N-terminal, is it N-terminal? N-tidal, sorry. N-tidal CO2. There are two types, mainstream and side stream. We only connect it when we have intubated the patient. We connect it either mainstream into the one or side stream, and it measures the CO2. Okay, so let's assume you win contract now. Please, at least supply the correct thing. Okay? Then ECG, and then your crash cards. Are we all together? All right. This is stuff. You need to learn it. You need to practice it. Without this, your ACLS will not be successful. You can never walk alone. You cannot know it all. You cannot do it all. So ACLS is useless if you are the only one that knows it. Okay? So common team roles. So the leader, 2 to 3 CPR performers, an airway person should be called, IV access somebody with medications, typically one nurse mans that, 1 or 2 nurses joins housekeepers and doctors to do the CPR. Somebody is checking the defibrillator, connecting it, making sure, and somebody is recording. Atropine, 2 milligrams given. So after a while, you're not sure if you have been resuscitating for a long time. How many atropine have we given? Somebody can tell we have given 4. You stop. Somebody can say we have given 8 adrenaline. We have given 3 shocks. Somebody must be recording. Hello? Fine. Hope the food is not too much. Okay? So those are the team roles. So the next thing is rhythm identification and treatment. This is the main part of ACLS. When you get to the point where you have to identify the rhythm, we did rhythm today, Abi? Well, and where you can now treat either cardiovet, defibrillate, pace, and medications. Okay, so I hope that is this. So successful ACLS treatment starts with the correct diagnosis of the ECG rhythm. That is what is the main bane of doing ACLS successfully. You must diagnose the rhythm successfully. If you do not correctly diagnose the rhythm, you are going to do something that will even make it worse. So if you diagnose the wrong rhythm and you shock the wrong person, or you defibrillate instead of cardioverting, you are going to stop the heart rather than start the heart. Do you understand? So getting the ECG diagnosis is critical. Besides the shockable rhythms, the rest of them, you have to read them. So in your defibrillator, there will be an ECG cable. Okay, there's another one. Have you guys brought the second one? Where's the comment? Okay, so there's another one. You can see this one has a full 12-lead ECG. So you connect the entire ECG cables to the patient. If you are doing a surgery, the person say he's coming for, what's that thing they are doing now? Brazilian something. Brazilian lifts or something, or liposuction, hypertensive something. Put all of this ready. Set your pads ready. Because you can see this patient is relatively high risk. So that ECG is there, you are seeing it. The reason why you need this, if you need to cardiovert, for cardioversion you must do what we call synchronized cardioversion. Meaning, you must shock exactly on the QRS, on the peak of the QRS. You remember that QRS? Your shock must be delivered at the exact time that QRS is landing. Otherwise, you will cause problem. So when you have set it, the ECG is there, you will tell the thing to synchronize. It will now synchronize it, and when you press shock, it will deliver the shock at the right time. But if there is no ECG there, the machine cannot synchronize. And you cannot know when the next one will come, so you press. It's not possible. So you have this ECG there, then you will press synchronize on the machine. It will synchronize it. It will pick up the ECG rhythm, synchronize it. Then when you shock, and you choose your voltage, you shock, it will now synchronize and bring the person back. Hello? You have not seen he's here. You can come after, walk around, look at it. Okay? And then go back and give somebody trouble. Thank God I'm not your MD. Okay. So typically, there are two sets of rhythms. Think of it simply. There are cardiac arrest rhythms and there are non-cardiac arrest rhythms. That is when somebody needs ACLS, he may be in cardiac arrest, or sometimes they're not in cardiac arrest. They are just on the ward without cardiac arrest. They are in your A&E. They are in your theater. You are doing the operation for them. They are in your labor room. These patients are everywhere. So, say somebody, he went for surgery, there was nothing, he just, somebody did not recognize something. It happens everywhere. Sometimes you recognize that you could not do the right thing at the right time. Okay? So, remember that there's cardiac arrest rhythms and non-cardiac arrest rhythms. For the cardiac arrest rhythms, there's the shockable and the non-shockable. If you put your AED during cardiac arrest, it will decide if it is shockable, it will say shock advised. Then it will tell you to press and then to shock. For the non-shockable, it will say no shock advised. Continue CPR. Okay? For these ones, the patient has come to you and you have found the rhythm. And you know this one may likely lead. So it might either be a very slow heart rate or a fast heart rate. If it is fast, we'll check whether it is narrow complex. Who remembers narrow complex? How big is narrow complex? Less than half a big box, Abi. And then wide complex is more than half a big box. So that is wide complex and narrow complex. Or slow, tachycardia, and then a slow heart rate. Okay? Is that straightforward? It's simple now. Hello? Any questions? About to take it a little bit harder. They are not shockable. If you put your AED and it analyzes that rhythm, it will say non-shockable. And if you are not using an AED and you have become guru like us, we look at it. This is PEA. Asystole is like flat line. Flat line. Don't mind the movies. It doesn't mean you should stop. Flat line. It's not like that. So in the movies, it will just become flat line and they will just say it's over. No, it's not over. You will continue what? CPR. Continue CPR. Okay? So, we don't have pulse. What is the ECG pattern in this cardiac arrest? Anybody? This person came with cardiac arrest and no pulse. Of course, no pulse. It's cardiac arrest. What's the ECG pattern? There is no pulse. Yes, anybody? Anybody? No pulse. But on the monitor, this is what you are seeing. Hello? Try now, try. Dr. Atakulu. Choose one. This is what you are seeing. And the person is in cardiac arrest. No pulse. But you put on the ECG and you are still seeing this. You check there's no pulse. You put there's no heart rate. But you are seeing this one. C. Pulseless electrical activity. So there's electrical activity. Maybe this, it may be something worse. But in this case, it is electrical activity that is pulseless. Okay? This one you cannot shock. Hello? This one you cannot shock. What about this one? B. D. Asystole. So sometimes you see some small flickers, but it's generally a flat line. Okay? Before you say it's asystole, check that your ECG cable is connected well. I'm telling you, it has happened before. It can be on the floor. You are there. There's nothing here. The ECG cable is down, just like it came down from there now. Please. Okay, so these are cardiac arrest rhythms. So in these two, these ones are non-shockable. What you do next is to exclude reversible causes. Hope I have them. Yes, exclude reversible causes. 5Hs and 5Ts. We'll talk about that. And then you continue your CPR. Give adrenaline. Repeat adrenaline every 3 to 5 minutes. And after checking the rhythm. Every 3 to 5 minutes after checking the rhythm, repeat adrenaline. Continue CPR. And recheck the rhythm every 2 to 3 minutes. Hello? So your monitor is there. You've checked it. It is this one or is this one. give adrenaline. Continue your CPR. Continue your CPR. 3 to 5 minutes, you check the rhythm, it's still there. Your CPR, bag, max, 32, 32. Every 2 minutes, change so that somebody can rest. Change. Bag, mask, change. Give your adrenaline again. Every 3 to 5 minutes, you check the rhythm. Continue. That's what you do. Sometimes, a lot of times, when you continue, the next thing you will see to change, the rhythm will change to a shockable rhythm. Then before the person comes back. So that is why you should not see that one and say it's okay. So what are the causes that you should check while you are doing that? This is why you need a team. Somebody else should begin to check the 5 H's and 5 T's. What are the 5 H's and 5 T's? These are the 5 H's and 5 T's. You should check, is there hypoxia? Is there hypo or hyperkalemia? Sometimes you need to get somebody to take the blood immediately. And if you have the iStat machine, you can take it and get it immediately by your bedside. You should check, is the person too cold? A lot of times people that have drowned, okay, they are now cold. You need to cover them. Okay, in our center, we have these special warming blankets that we use for cardiac surgery patients. You connect it, and then it blows hot air inside the special blanket and warms the person. Those are some things you should consider immediately. So, correct hypothermia. If not, get warm blankets, get blanket plenty, put it, wrap the person. It is said that you cannot say somebody has died until they are warm and dead. If the person is cold, there is still a chance, in fact, a better chance that you resuscitate that person. So until the person's body has become warm, you cannot truly say that person has died. So if you say the person has died, that's why the ones that they say they woke up from dead. Somebody did not finish CPR, he just say, Then later they say the man woke up. Okay? Fine, what again? Acidosis. Then thrombus. That means pulmonary embolism or MI. That your ECG, get your ECG. Check for it. Tension pneumothorax, you may need to just put a needle there. So somebody is checking why CPR is continuing. Tamponade, toxins, sometimes they're taking Igbo or something else, Abi, or trauma. So you need to address all of that. So what rhythm is this? Still cardiac arrest, no pulse. B. A. Open your ECG. I think it's there. Open the ECG sheet in your this thing. Check for it. Look there. Look there. Well, I'll give you everything you need to succeed. All that you need for life and godliness. What is it there? Are the rhythms there? I think they are there. I hope I did not forget to put it there. Is it there? It's not on that one. It's not in this book. On that sheet with ECG. There's tachycardia. Oh. The revised one will have it. Okay, so what is this one? Jaga jaga. Jaga jaga is A. Ventricular fibrillation. No, it is irregular. There is no detectable rhythm, but there is something there. That is A. This is a shockable rhythm. You must shock immediately. If you see this one and you have a manual defibrillator, shock. Turn it to 200 biphasic and shock. Don't wait for things to start reading. This is a ventricular fibrillation. In a short time, it's going to go to PEA and asystole, and you will have a very hard time. Hello? So just think about it. Irregular, scattered, almost jaga-jaga, ventricular fibrillation. Sometimes some people refer and say ventricular fibrillation in a referral letter. I say, you saw it and you refer the patient. If you don't do anything, the patient is going to be their creator. Okay? So you need to have this done. Look at the 12 lead of it. What you can see it. This is what the 12 lead will look like. Sometimes the people, if you have an ECG technician, your ECG technician will just be doing ECG and see this one. Patients are doing like this. Hey, they should know what to do. They should start CPR immediately. The same thing you do for cardiac arrest. Start CPR, call for help. After somebody sees this one, you shock immediately. You get the person back. We all know this, Abi. Anybody that cannot recognize this again? Anybody? Straightforward. Once you see chicken writing, Dr. Aho says, once you see chicken writing. Again, check that the ECG cable is not on the ground. Check, because it could just be disconnected and hanging. You not connect it back. Sometimes somebody writes it because the patient will be gisting. Then you see this, he goes, check. Likely is that your ECG is not connected well. Okay, fine. Again, I remind you, you will get all the slides by the grace of God, hopefully between next week. You get all the slides to the email. So if you don't write your email well, sorry, you get it from your friend. What ECG is this? No pulse, cardiac arrest. So you have a regular here, in this case regular, wide complex. Hello? Wide complex regular tachycardia. In this case it's irregular. So this is called a pulseless ventricular tachycardia. Sometimes you can have ventricular tachycardia with a pulse. The patient is just feeling somehow they are there. You will not defibrillate. You will do something else. Talk about it. So again, for shockable rhythms, hope I corrected this one. For shockable rhythms, shock. Sorry, mistake. For shockable rhythms, pulseless VT, VF, shock. Sorry about this. Shock. Give adrenaline. Shock. Continue CPR. I'll correct it in your slides. So cardiac arrest happens. Can we see that? Check the rhythm. Start your BLSO. While your BLS is there, you have set up your rhythm. This ACLS now, we're not in ACLS. BLS has been continuing. Now your rhythm. Head matron has come in. She just finished from ACL, from Abuja Cardiovascular Symposium. Abi, you land. Today as you're leading Kefi or where, they just say, you have come. I will not be there. I will not be there, I promise you. So, you found out that it was pulseless VT or VFib. You remember? It looked like this or like this, and there was no pulse. Patient is in cardiac arrest. What do you do next? You were doing CPR before now, then you continue. You are continuing your CPR. What do you do next? Shock. Don't be afraid. Shock. Shock. So what kind of shock is this? It's a defibrillation. Because it is jaga, you cannot synchronize. And you have to give a very high Q. So you start with 200 typically on a biphasic. Or does it change to 360? Sorry, I'm very tired. And then continue CPR. You continue that. If it is asystole or pulse electrical activity, you remember those ones? Flat line or just some electrical activity but there's no pulse. What do? Continue CPR. Give adrenaline, remember? 1 mg, typically 1 ampoule. And repeat every 3 to 5 minutes, we said. Continue your CPR. Are we clear? One time, some people told me that their AED is not working, that every time it's always saying no shock advised. What does that mean? It was picking these kind of rhythms. So it was not as it was not working, you're picking this kind of rhythm, so they said that is not working, Gary. So they stopped using it. Okay? So you have to know that so that you know what to do. So adrenaline every 3 to 5 minutes. Check and treat in all of them. Be checking. Somebody else should be checking and treating any reversible causes. If you see hyperkalemia, start giving your drugs. And then if it is for not this one, if it's for pulseless VT or VFib, you are giving the first shock. It continues. Second shock. By the second or third shock, you should start adding IV amiodarone. IV amiodarone, for this case, is 300 milligrams. Write it down. IV amiodarone, 300 milligrams starts. IV amiodarone, 300 milligrams starts. And then you continue with 150 milligrams, if you have to repeat the dose, or you put in infusion. 300 milligrams starts. How many people have seen IV amiodarone? I didn't see it till I became a cardiologist. So don't listen, it was when I became a cardiologist I saw it first. So it's not everywhere. But now you have come for ACS. You are going to your center and you are saying, sir, we need IV amiodarone. All right, I showed you this ECG this morning. This ECG this morning in the cath lab, we had this. What rhythm is this? Hey, people are quiet too. What is the rate? What is the rate? Can we see the lines? It's about 300, Abi. Good. What is the what rhythm is this? Huh? This is real life, oh.
Someone I sure should answer.
Talk now, talk. Say it boldly.
Ventricular tachycardia.
Thank you. It is regular. It's not jaga like chicken scratching. It is regular. It is coming regularly. Abi, wide complex regular tachycardia with no pulse. The person has gone. I told you the man went. He started even convulsing. The man went, and then when we now woke him up, he now said, "Why are we disturbing him?" So this is what? Pulseless ventricular tachycardia. After that, there's one man. He had MI. He had all of this. We resuscitated him. He came back. We said, "Okay, let's rush and give you tenected place or take to the cath lab." He said, "No." That how much? No. Nobody should tell. On top of what? That is malaria. The person that had woken up from this, he refused though. We couldn't force him until he had another cardiac arrest, and we were unsuccessful. That's about 5 years ago. We were unsuccessful reviving him. The wife called me to say we should not mind the man, that we should not mind the man, we should not. But there's no way you can override a patient's wishes. We cannot carry him to cath lab by force. We cannot give him anything by force. The man says, "How much?" You are not serious. I'm telling you a real life story, not be joke. It was nice. I think Dr. Oleleko was one on call that day. Okay. I think that's basically it for that. So, shockable rhythm, yes or no? You have this in your book. This is page 31. Shockable rhythm, yes or no? If it's not a shockable rhythm, that's asystole or pulse. Give your epinephrine. Continue your CPR. Repeat your epinephrine every 3 to 5 minutes. Consider advanced airway. Check again shockable rhythm. If there is none, continue your CPR. If there is a shockable rhythm, administer your shock. Continue your CPR. Get access. Check shockable rhythm again. Give your CPR. Continue give your epinephrine every 3 to 5 minutes. Shockable rhythm again. Give shock. By the time you are getting there, start getting that amiodarone. So if you don't have amiodarone, you have lignocaine. Everybody has lignocaine. The same one you use for local anesthesia. Hello? The same one you use for local anesthesia. That one that if you mistakenly put inside the person's heart will stop. If you give that one inside somebody's vein, mistakenly, the heart will stop. Okay? And if that happens, start CPR. Start CPR. People have made the mistake before. They wanted to give ceftriaxone. You know, they put it with lignocaine. They've withdrawn it before. One of my SRs that time, there was strike. He was giving drug. He was tired. All our officers also followed the strike. It was 2 a.m. He had given like 20 children. He said as he just gave, it just occurred to him, what did he give? The child just stopped breathing. He ran like this. He said the clarity in his mind, he continued CPR for 30 minutes because the child was fine, about to be discharged. The child came back. Then he told us the story. We were all cold. We were all cold. Okay? So fine. So I'm telling you this story so I can stay awake. And then you can remember the stuff that we are teaching. So give lignocaine if you don't have amiodarone. Okay? I've forgotten those of lignocaine. Can somebody help me check it up? Okay, number 2 now. In this case, this is not, remember we said there are cardiac arrest rhythms and there are non-cardiac arrest rhythms. Remember? In these non-cardiac arrest rhythms can be either fast or slow. Not so? The fast ones can either be wide complex or narrow complex. Beautiful. Hello, a lot of people are quiet. Don't be quiet. Don't be quiet. So, when your heart rate is fast, ask yourself, is this person unstable or is he stable? If they are unstable, what's the meaning of unstable? Blood pressure is too low. Patient is in shock. They have chest pain. They are altered sensorium. So you were doing your vital signs and you saw this patient, and sometimes if you don't find during ward round, the person just did like this. You check the heart rate 150, 160, he's unstable. Or they are complaining of chest pain. They are complaining of chest pain. They rushed into your clinic. What do you do? Unstable. What do you do next? Cardiovet. Cardiovet. This one you don't shock. You cardiovet. Why? It's not a cardiac arrest. Hello? Hello? Unstable tachycardia. Unstable tachycardia. Cardiovet. Not in cardiac arrest. The person has a pulse. He's just unstable. Blood pressure is low. Blood pressure is 70-50. The person is having some chest pain. They say they are feeling lightheaded. They are feeling like fainting. Okay? You say, don't worry, pour water on the head, drink Coke. No. So, if they call you and somebody says he's feeling like fainting, he's feeling sick, check the pulse, check the heart rate. If you notice the heart rate is already fast, connect your monitor. Start ACLS immediately. What you are dealing with is ACLS. Check. That patient is not stable. What you do to is get your monitor together and cardiovet. Okay? You cardiovet and then you continue with medications. If the person is stable, what do? You start checking. Is it wide or narrow? Hello? Don't get tired of me. Oh. Me too, I'm tired. If you are feeling sleepy, just stand up. In fact, let's stand up for 1 second. This is the meat. 1 second, we are standing up. Stand on your toes. Up, down, stretch, up, down, stretch. Good. Take a deep breath in, out. Again, we're going to take it this time very well. In, hold it, and out. Good. Now let's have our seats. Great. Let's clap for ourselves. Clap for yourself now, not for me. Some of you don't like yourselves. All right. Please take this very serious. Maybe we should have done this first thing in the morning. But then we have not learned ECG. So you will not have known anything about it. Okay? But this will be critical. This is life-saving. So the patient is stable. Check, is it wide or narrow QRS? We all can do that now. We are all ECG experts. If it is narrow, start with vagal maneuvers. What are vagal maneuvers? Who can give me an example of vagal maneuvers? Valsalva. How can I explain Valsalva maneuver? You should do as if you want to use the toilet. Or you want to give birth. Bear down. Blow out breath against a closed glottis. So, or hold your nose and mouth and blow out. Can we try that? All of us try it. Hold your nose and mouth and blow out. Try and breathe out without letting any air come out. Have you done that? That's what you're going to teach your patients. Okay? Another one you can do is carotid sinus massage. Okay? And I've done it before. I think the last patient I did stand for. As soon as I opened the RCA for him, blood supply to the area, the guy started having SVTs. Narrow complex tachycardia. One day you remember. And I was the only one inside the cath lab. So immediately started massaging. Get the carotid, feel it, and then massage. And the reading went back to normal. Okay? No, we did not need anything extra. Okay, so you know that one. So you have carotid sinus massage. You have what again? Valsalva. Yes? Please don't do both of them at the same time or you will kill the patient. Don't pray both of them. You will stop blood flow to the brain. The patient will go unconscious. One side, feel the pulse and do it. If you have time, you may need to do a Doppler to make sure that there is no plaque there so that you don't rub it and the next thing the patient has a stroke. So those are the things you should take. So start with Valsalva first. But if you don't do anything with this narrow complex tachycardia, that patient is going to have a cardiac arrest. It's just a matter of time. So you need to do what you need to do. There is no time to call anybody to refer anywhere. You are the one standing between that person and their maker. All right. If it's narrow QRS, you can do vagal maneuvers, and then if vagal maneuvers fail, you can continue into drugs. And we'll talk about the drugs shortly. Remember, IV access should be there, oxygen access should be there, monitors should be there, ECG should be there, get specialist input. Not referral, input. When you are stabilized to an extent, then you can now start. If you must refer this patient, you must go with the patient. This is not the one you give driver to go, enter Uber. Or start describing, this is how you get to cardiac care, left, right. No. You must go with the patient, because that patient may likely enter a cardiac arrest. They are talking to you now. The next minute is all over. Okay? So check and treat reversible causes. This rhythm can be changing, so you need to be evaluating the rhythm regularly. So synchronized cardioversion, I've explained it already, but you need to know this. You need to know this. You are going to paste this in your emergency rooms. Nurses, doctors, you are going to paste your emergency room. You are going to keep it on your phone. You are going to keep it on your phone for narrow regular when you have to cardiovert. This type, you cardiovert typically for, who are the people you cardiovert for? Yes? Go back, you wrote it now. Who do you cardiovert for? Unstable. Unstable people with tachycardia that have a pulse. Tachycardia with a pulse. They are not in cardiac arrest. They have a pulse. Pulse is 150, 180. Sometimes 200. We have seen them in the clinic, 200. And they are feeling somehow, they are looking at you. There's one man they brought from Benue. He was looking at me like that. Professor, it was, it was going like that. Okay? So you can do that. And if it is narrow and irregular, you use biphasic 120, use a higher joule. Wide regular 100 joules, and if it is wide irregular, you are likely dealing with a polymorphic VT. You should defibrillate, because pulse is unlikely. Maybe you are feeling your own pulse. You should check this. Wide and irregular one, you should defibrillate. That is, you turn to 200 and you shock. You don't have to synchronize. Questions? Anything I should take over again? Just lift up your hand. Don't worry, we are here to, that's why we are here to learn. Just lift up your hands. We are here to learn. Any questions? Okay.
Thank you very much. My question is, in a patient with that's unstable with tachycardia, with pulse, and you made a diagnosis that the patient is hypotensive. Will IV fluid go a long way in bringing back the patient to normal, or we have to cardiovert anyway? Thank you.
Thank you very much. That's a very fantastic question. The instability in that patient, the hypotension, what is causing it? So when people have tachycardia with a pulse and it is due to hypovolemia, it rarely crosses 140. That is the hypovolemia causing tachycardia. Is rarely, if at all, 130, 140, tachycardia 130. When it starts crossing 150, 180, then what is causing the hypotension is not just the hypovolemia, it's the tachycardia. So remember, you are checking reversible causes. What are one of the H's? H. What's the H? Remember? Hypovolemia, B. So while you are doing the hypovolemia, what is it? While you can start your fluid, but you must still cardiovert. Otherwise, that fluid will not reach to solve any problem. Are you okay? That's what's happening. So you can be correcting it, but you must cardiovert, because it is crossing 160, 180, 200. It is not a normal. It's not a sinus tachycardia. It's not a normal response of the body. Okay. Is there any other question? There's somebody at the back there. Ooh, I'm tired. You sure you'll not come and take over from me?
Thank you for
Thank you very much for your presentation. Please, I wanted to ask you for other examples of electrolyte imbalances which are reversible, can trigger the what have I said?
Just trigger the cardiac arrest,
yes,
or
cardiac arrest.
Or the unstable rhythm.
Yes, the unstable rhythm. Thank you.
You're asking for other abnormalities?
Other electrolyte abnormalities.
Hyperkalemia, hypokalemia, those ones you mentioned. Calcemia too, sometimes, hypercalcemia, all of them, they are there. So calcium should be one of the things. If you have hyperkalemia, you will see use calcium gluconate to help you protect the heart while you are giving glucose and insulin. Okay, so all of them are there. But typically, in this place, more times we see calcium, and then you see severe acidosis. Okay, so that's one of the H's. All those H's that you saw, that is where it is. Okay, those are the main ones. So again, if it is a wide, complex, regular antiarrhythmic drugs, these are the drugs you can give. The patient is fine, he has a pulse, he is not hypotensive, he's stable. What do? You can give your amiodarone infusion. If you look on that page, what number is that? Is it there? Page 34. Page 34. You will see the doses of the cardioversion you are giving and the dose of the drug. Please open it now. Page 34, so that if you have any questions, you can ask. Page 34. You will see there, synchronized cardioversion, narrow regular 50 to 100, irregular 120 to 200, and so on and so forth. And then for amiodarone, the dose is there. Okay? So those are the doses. For narrow complex, give IV adenosine. Adenosine is quite difficult to find, and you must give it very fast. And when you give it, you must flush it because it disappears from the body in seconds. You must make sure that the rhythm is regular. Never give adenosine in an irregular rhythm. So it's not regular, do not give adenosine. But don't worry, adenosine is hard to find. So it's probably not, you probably have less chance of making a mistake. Hello? So you can call us later, we'll come and audit your hospital to see whether you're ready for emergencies. And then beta blockers and calcium channel blockers. So if it's adult bradycardia with a pulse, this all the one we're talking about is tachycardia, Abi. If, however, that pulse is now very slow, less than 50, less than 40, we have seen 26. We have seen 26 before. How many people have seen 26? Nobody. Anybody has seen less than 30? Nobody. Less than, okay, 2 people. Anybody sees less than 40? Nobody. Okay, so less than 30. What did you do for them? You prayed with them? Okay. So, again, stable or unstable? Again, understand? Stable or unstable? If they are unstable, that is hypotension, shock, chest pain, heart failure, altered sensorium, and you are getting that, atropine is what you should give. Atropine will only work in certain situations. It will not work in many situations. You can also give dopamine or epinephrine infusion. That's adrenaline infusion. You can give that. Or, like I said, you can do transcutaneous pacing. But transcutaneous pacing is painful because it's sending shock. It's shocking from the front to the back. So you put this pad in front and at the back, turn it to pacer. Where's this thing now? I'm sure that one, sir. Or maybe it's a soft. Okay, see pacer here. So you put it on pacer, and that one is there in front there. Maybe the camera can point to it and show it on the screen. Please, can you zoom in on it? So you can see that one. You can see AED, pacer, then monitor. So you can turn it to a monitor setting where it is just monitoring your ECG for you, or you turn it to pacer mode. In this case, select and then you start the pacing. So you put the pad one in front, one at the back, and then it starts pacing, especially if your atropine has failed. Then you can carry them. Most of them have batteries. and you can now move them with that until you get where we can put in something to help them. If you are too far away, you continue atropine, start dopamine, and then you trust God till you get here. Okay, so what do we do in cardio care? We can put in a temporary transvenous pacemaker. We go to the jugular and pass a pacemaker probe into the heart, or preferably we go to the femoral vein, just cannulate and pass it. Anybody can do it. It's not hard. I assure you, it's not hard. You pass it straight, you get into the right ventricle, and then you put on. You have a device. The device is a temporary pacemaker. You hang it on your drip stand. I didn't bring the device here. You hang it on the drip stand, you connect it, and you press on. You put normal batteries, Duracell. Make sure it's original. Put it in battery, and then you press on, and then it will start pacing. So that one is inside the heart. Then you anticoagulate. You have that one will give you a longer time and do not be shocking the whole patient. You know this one is shocking the whole patient. Every time he wants to beat the heart, it will shock. Shock. So once you pass that one, it's now more stable. You can now prepare, get your normal pacemaker like I showed you earlier today. Take an incision, subclavian vein, axillary vein, any of the veins, go to the heart and connect it, and boom. If you think it's a permanent problem. If it's a temporary problem, go and solve the temporary problem. It could be an MI, do your angio stent. It could be a drug they have taken. It could be digoxin. You just continue that till it wears out from the system. It could be that the person took digoxin, took beta blocker, took amiodarone all together. He went here, he said his brother was taking this drug. He said this, I get heart problem. I wait till I also take. Bam, they took all of them. Bam, patients do it. They will not tell you. So it now went down. So you just have to pace them till that thing passes out. You make sure the kidney function is going. You are giving fluid. Once it passes out, the heart rate starts coming up. You reduce your pacing rate and the threshold until you see the normal reading picking up, and then you remove it and you are fine. Hello? Does it sound far away? Hello? Does it sound too far away? So what you need to do is just to make sure you get one of these. Make sure you get one of these in your hospital. Go there, and if you already have it, you probably have not noticed it before. Check for it. You came for ACS. So your medical director, I will tell them, they should call you, they should look for you. That you are the one that came here, you know what to do. Beautiful. Fine. And I think we can more or less end. After the patient has returned, the patient is fine, the heart rate has come back. Please, typically we like to intubate. A lot of times, you might enter the airway, intubate, get the SpO2 up to arterial blood gases, maintain the blood pressure, get a full 12-lead ECG, and then start the real treatment. Because you have returned the person, you have not yet solved a lot of the problem. A lot of times we rush the patient straight into the cath lab. Hopefully there is no financial constraint or the person has a good insurance. Okay? One day insurance will be covered in this country to the point that anything happens to anybody, we can call and we are sure that everything is covered. Amen. Yes, one day is coming. One day is coming. But till that day, we have to learn and be ready. So that there will be many people that can do everything until they get the patient to where they can get help. So if you have done that, you put all of this, follows command, you do other critical care management. If the person is unconscious, you will now have to manage as a coma patient. Sometimes you have to trigger coma yourself and do targeted temperature management. Okay. Ventilate, treat reversible causes, maintain hemodynamics, and get a specialist input. Advanced airway is all about putting endotracheal tube or laryngeal mask airway. Okay? Typically, your anesthetic nurse can help you, your anesthetist can help you, or preferably learn. I think in our children's hospital, we have a mannequin for training how to put for children. I don't yet have one for adults. If not, we'll have. But that one is very, these are very expensive and we cannot do for 400 people. It will just destroy. Okay? So, you should try, there should be somebody on staff somewhere. If they're not on staff and your hospital is small, at least know somebody. Know where your help is coming from. So as you started your CPR, started doing this one, call for the person. Let the person come, open the airway, put it in. Okay, we have not always had all of that. We call some, they will be driving fast. They will call me too. 10 minutes. It takes me 10 minutes from my house at 140 kilometers per hour. Fiam! I get there, we shock. Immediately I get there, I get to the foot of the bed, and just like we talked about. Okay, so that's advanced airway. And then the final one is specialized life support systems. This includes taking the person to the lab. You need to open that vessel as soon as possible. It includes an IABP. So we have this device. I wanted to put a video, I forgot. We have this device called an IABP. I'll put it on the WhatsApp group so you can see what it looks like. The same way we did the coronary angio, instead we put a very big balloon in the aorta. The balloon will give counter pulsation. Whenever the heart pumps, the balloon will also, after the blood comes, the balloon will also pump a bit and push the blood. So it will help the heart. So the heart will not do much work. To pump it again, some blood will go back and perfuse the heart properly. The rest will help to perfuse the rest of the body. Okay? And we had one case, a policeman came with an MI. Yeah. Came with an MI, cardiogenic shock. We was on 3 drugs, nothing. That is an ACL waiting to happen. We put the IABP, we stented, we thrombolized him first, called a facilitated PCI. Because he was too sick, we had him sign a high-risk consent that this one, oh, if you don't do anything, you die. If you do something, you may die. So, sign. So we first thrombolized, and they didn't have money. Thrombolized, then we went in, opened the stents, and then put an intra-aortic balloon pump while we were doing the stents. So all of that helped the heart, was pumping, helping the heart to pump. And afterward, urine started coming out. In a day or two, we brought him out of the ICU. He went home. He's still coming for follow-up for now. Unfortunately, his wife left him after he was discharged. I don't know why. But she tried for him. Oh, she called everybody. I mean, I was so impressed. So I was like, "Where is that your wife? That your wife really tried?" She said, "Ah, she left me." I said, "Ah." I don't understand. We'll have a CME on understanding that kind of thing later. All right. Great. This should be your crash cart. Your crash cart in your hospital, this should be there. If you don't have a crash cart, please have a cupboard. Call your carpenter to subdivide it for you. It must be there. You came for this program. Don't go back and leave yourself anyhow. I've written what I can remember now. We have a standard checklist that we use. Maybe if I remember, I'll put it on the group as well. But this one is there for now. Amiodarone, adenosine. I put a standard adenosine. You may not be able to find it. And when you find it, you may not use it till it expires. Okay? So you should also know that. Some of these drugs, you may not use them. They may expire on your hand. Luckily, by high volume center with very high risk cases, so we use them. Okay? But if you don't have them, the day you need it, you will pray to your lucky stars that you had it. Okay? So if you're in private practice, charge for the ones that will expire. Make sure that it's there, sha. Atropine, bicarbonate, calcium gluconate. Somebody asked about this thing. Dopamine, dobutamine, diazepam, 50% glucose. Why is 50% glucose there?
Hypoglycemia.
Hypoglycemia, one of the H's. Labetalol, lignocaine. Why is lignocaine there? If there's no amiodarone, you can also, some people even use it first instead of amiodarone. So it can be either both. When do you use it? Amiodarone or lignocaine, when do you use it? Huh? Shockable rhythm. Yes.
Reading.
Go back, check. When do you use it?
Cardiac arrest.
Cardiac arrest. After 2 to 3 shocks. That is what a refractory ventricular. So you shock the person, the thing remained. You continue CPR. 2 minutes you check. You shock, it remained.
Give your adrenaline first.
Give your adrenaline and continue adrenaline every 3 to 5 minutes. While you are continuing shock. By the time you are getting to the 3rd time, technically 2nd to 3rd time.
Give your amiodarone, 300 the first dose, then subsequently 150.
And we've had fantastic results. It's so sweet. When it works out, it's so sweet. When it doesn't work out, it's so terrible. Why? Your whole body will be paining you because of all that. Bring, shouting, all of that. Then to make matters worse, the patient relative may still come and still insult you on top. Do you understand? So
why do you want to collect money when the patient is dead?
Exactly. And you use as in you emptied your crash cart, you intubated, you shocked, you finished, these pads. You have to order, there's nothing in this country now, so definitely we don't make this. So you shocked, you transcutaneous paste, you did everything, you called 3 cardiologists were there, after you finished, the patient still did not make it. See fight. Okay? So, but what I would advise you, if you start, it's not in normal ACLS, but for Nigeria, if you start ACLS or BLS resuscitation, inform the family why you start. Okay? Sometimes, let them even come and peep in and see what you are doing. So it will not be that they left the patient now, and they came back and met him, what did you do, Seth? In fact, you're the one that killed him. Do you understand what I mean? So once you start, in our experience, it's good to send somebody out to inform the family, let them know. And also, you need prayer. Abi? Last. You need prayer. So have oropharyngeal airway, endotracheal tube, laryngoscope so that you can intubate. Please make sure you don't have laryngoscope without batteries. Batteries should be there. It should not be inside, it should be by the side, and it should be checked every day. Somebody's work should be to check all of these drugs every day. Okay? Ambu bag, oxygen tubing, suction tube, Yanka short suction. Are there any other things?
Oxygen itself.
Oxygen. Oh, well, if you have oxygen in your hospital. Okay, fine. Some people have oxygen attached to their crash carts. So when they just move the crash cart, there's oxygen, you just connect it. The face mask, you connect it. The ambu bag is there, you bring it out. You will bring in your drugs. It even have an IV pole connected. So you hang your IV fluid, you start. If you need amiodarone and you put your IV. So that crash cart is containing everything for life. Where I was training, when the patient starts doing somehow, the nurses will just move it close to the bed. The relatives will just start crying. Hey! All right, fine. We are going to try a small test. And I will give you a website. Somebody can help me find the website. NHCPS. Somebody will help me find it. There's a mega code there. You go there, I'm going to try it. It times you because you have 2 minutes or so, 3 minutes or so. So it's going to time you while you are going through what you are going through. And every time you fail, it will tell you have failed. This is not what you're supposed to do. You do it again. You keep on practicing. Even we do it, we fail. Do you understand? I do it sometimes. I fail. The one I did yesterday, I failed. Yes. Why? Every stuff has half-life. It's gradually going down every day. You have to be refueling. Some people say they're not coming this year because they came last year. I say, how many heart attacks did you see between last year and this year? The stuff will be going down. Okay? So, ACLS medical code. Let me just try one case. I have
the website, nhcps.com/ACLS-mega code. nhcps.com. I think I'll get someone there to type it. nhcps.com/ACLS-mega code. I can type it. Let's type it.
We'll put it on the WhatsApp group for you as well. Please endeavor to try at least. That's the website. Endeavor to try at least once a week. Keep your half-life up of your stop. Okay, just write the website, and when we want to just try one, we'll try one now. Are we all together? Just write it down quickly and then look up. We are going to do a small test. Maybe we can browse with this one too when we finish and try and do 1 or 2 days. Are we all together? All right, let's look up. A 52-year-old man collapsed at a political rally. I will not say which rally. Okay. Bystanders perform CPR at the scene. They say your hospital is the closest one. They rushed him. You're the only one on duty. but you came for ACS 2022. You had certificate to show for it. It's on your wall. Pulse, tready, blood pressure 60-30, SpO2 95%. CPR has been done. Question 1. What are the initial steps in management? Yes. I need a microphone. Somebody. Cardiovet. Somebody say cardiovet. Yes, is that the does cardiovet have it? Say again. Give somebody. Be bold now. ABC. How can you cardiovet what you don't know? Is it VFib? Is it VTAC? What is it? Is it asystole? Is it bradycardia? Hello? So first, ABCs. Check the airway, check the breathing, check the circulation, check all of those things first. Okay? So, ECG came out like this. Time is going. VTAC, you think? Initial management. Now we do ammo.
Don't forget that anytime we're talking about VTAC in ACLS, you have to specify whether it is pulseless or the one with a pulse. So you have to put it on
stable or unstable.
So
is this stable or unstable? Somebody say it's stable. Unstable. The unstable say aye. The stable say nay. The ayes have it. Why this is unstable? Hypotension. Good. Hypotension. So it's an unstable, wide, complex, regular tachycardia. Right? Unstable, wide, complex, regular tachycardia. He's not in cardiac arrest anymore. He has a pulse somewhat. Blood pressure is there. He's looking at you. So what do? Cardiovet. Cardiovet. Synchronized cardioversion. Okay. So, what dose of cardioversion do you use? Open your book. Open your book. Open your book. Open your book. Don't kill the patient, oh. Go to page 34. Page 34. What did you see? 100. Somebody said 200 before. You don't burn the man. You have burned the heart off. You can see that this thing, it doesn't stay. Even after 2 weeks, if I go back, I may not remember that it's 100 because you have to keep on doing and doing till it becomes muscle memory. Till you don't have to think and it comes up. Hello? Great, 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 great. So we say 50 to 100. Yes, 100 joules from our book. Now, which of the following should be used for pulseless VT? I wish we had poles here. Anyway, it would have been scattered.
It would have been scattered.
Yes? Which of the following? Open your book, what you wrote. Check this thing. Give microphone. Let me see a bold person. Give him. He said what? Somebody said 3. 1 milligram adrenaline, 300 milligrams of amiodarone. Why? Give him now. He was one talking. The man with suit in front of you.
I was not the one.
You want to deny yourself?
I was not the one.
Yes, somebody now. Somebody try. Go ahead. Go try. Why?
Okay, 3.
Why? Why? What rhythm is this? What rhythm is this? Pulseless VT. Right? Hello? What rhythm is that? Pulseless VT. Is it shockable or not shockable? Shockable. Shockable rhythms you give. Do you give adrenaline? Check. Do you give adrenaline? Yes, you give adrenaline. And you repeat it how often? 3 to 5 minutes. After you have shocked 2 or 3 times, what do you now bring in? Amiodarone at what dose? 300. Correct. And then subsequent CPR. You are right. You're not sure. You're right, but you're not sure. Okay. Isn't that not simple, isn't it? Continue your normal CPR and you are changing the people. And you are changing the people. Okay, I think that's about it. If this patient, you give this one, and the patient still continues with VFib, what do you do next? Maybe try and open the website and let's see. What do you do next? Continue CPR, and then what next? You repeat the amiodarone now at 150 milligrams. And followed by adrenaline every 3 to 5 minutes. And you shock again. And you continue CPR. Okay? Chicken, that's ACLS for you. Eh? When do you stop? So
you can do your amiodarone up to, I think, 6 cycles.
Yes.
So the first one is 300 milligrams. So you'll be alternating amiodarone, adrenaline, amiodarone, adrenaline. So once you give up to 6 cycles of amiodarone, you can stop and just continue your CPR with adrenaline. So, but adrenaline comes first, then you'll be checking every 2 minutes. But the thing about the mega code is, and the real life is, the patient will not permanently stay in VFib. It can change from ventricular tachycardia. The next thing might be bradycardia. So everything comes in together, though it's discussed separately, but you can have the whole spectrum in a single patient. You can move from ventricular tachycardia to ventricular fibrillation, from there to bradycardia, from there to normal sinus rhythm.
Somebody asked a question on
how often? Till you stop. It is either the patient return to return of spontaneous circulation, or PA for 30 minutes, and you just have to call it at that point.
As far as they have a shockable rhythm, you cannot stop. As you are doing that and it's not getting better, you should go back and check your 5Hs and 5Ts. You are missing something. In fact, in some cases, you are doing that CPR and moving the patient into the cath lab. People continue the CPR while we are doing the angio. We have done it before. You are doing the CPR, we are doing angio, we are looking, it's very difficult, but you are trying to get there. Or sometimes you thrombolize while they are doing that CPR. Okay? So, pulmonary embolism, so far you have that. So, the other alternative is, if you have had PEA and asystole for 20-30 minutes, and you have continued, and there is nothing 20-30 minutes, that's another way to think about it. Then a third way is, if you have the end-tidal CO2, if it remains less than 10 millimeters of mercury, yeah, 10 millimeters of mercury consistently for 15 minutes or so too, is also a sign that you may need to stop. The likelihood of coming back is very slim. Now, if you get it less than 10, that's on your monitor. If you have that monitor, and we will get it, don't worry. If you have that monitor and you are getting less than 10, it's a sign that your CPR is not effective. You are not pumping enough, your ventilation is not correct, and you don't have a proper advanced airway. Okay, so those are things to know. Now, sometimes it may also be a sign that your endotracheal tube entered the stomach. It happens. You think you are put an endotracheal tube, enter the stomach, you are pressing, there is no air. It has even blocked the trachea properly. So there is no air at all going to anywhere. Okay, so this is what the website looks like. And I think we should try one of them. But I also pick at random.
Okay,
so a 54-year-old presented to the emergency room with chest pain. So, and this is the reading you have. So, what will you do? The question is, what is the next best step? Can we move it up so that people can see? What is the next best step? Defibrillate, start CPR, intubate the patient, check a pulse.
Say it again. What answer the issues?
The time is going.
The
Okay.
time is going up. So we wasted so much time. Check your pulse, right? So my people said check your pulse, right? So you check the pulse, and it's important for you to know, like we said, if you see VT, you want to know whether it's pulseless or it has a pulse. So go to the next slide now. The patient does not have a pulse and a high quality CPR is initiated while you prepare the defibrillator. What's the appropriate joules for monophasic and biphasic defibrillators?
So which one are we choosing?
A, B, C, or D? Yeah, sure. D. Yes. Okay, okay. Okay, so you think it's 120 for mono, 360 for biphasic?
So which one are we choosing? They said D. Let's.
It's B.
B.
So you tend to need less voltages for biphasic.
For biphasic
because it's coming from both
for
directions.
monophasic.
Okay, so it's B.
So next.
Okay, so next. So put that in your mind now already. So you have defibrillated the patient, but the patient remains pulseless. What is the next best? What's the next step? Say it again.
C. Continue CPR, administer epinephrine.
So that's perfect.
So next.
So next, and what medication apart from epinephrine can be given next?
Administered now. Amiodarone.
Okay. So that's a good answer. Next. So if you administered your next round of medications and performing another round of CPR, then you
have
see
this
reading on the screen.
So what's the next thing? What's your next step?
Hmm?
What is your next step? What is your next step? Check your pulse, cardiovert, defibrillate, administer amiodarone.
What's the reading, first of all?
What do we have now?
Okay, so when you have VTAC, you want to know whether there's a pulse or not. Okay? So next. So your patients...
Now develop this. What do you do next? What is the reading first? What's the reading? What's the reading? VFib. So what do you do next?
Is there epinephrine, cardiovascular, CPR,
CPR,
or defibrillation?
defibrillation.
Say it again. So defibrillate by the mercy of God. So if it's defibrillating, you need to defibrillate. Okay, so you do this. So when we're going through it individually, you should read it. So I think we can afford to read that now. So,
So the idea is, like I said, it's going to take you through, because real life is not just going to follow this, a single path. It keeps moving depending on what is happening to the patient. So you can move from the tachycardia to bradycardia. So that after your amiodarone, the next thing may be atropine or whatever. So it depends. So you're going to follow it. So it's not going to happen the way we have discussed it, that, okay, the one with pulse, the one without pulse. And that is why it's a team effort. As you're doing, somebody is looking at the monitor, somebody is giving the drug, some people are doing the chest compression, and we're going to continue like that. So, any question?
any questions? Oh my God. Okay, I think time. Thank you very much. Thank you very much.
All right, thank you, everybody. Thank you, Dr. Iseko, Dr. Opse, and Dr. Lalekon.